Hi everyone, in this video I'll be discussing the next important topic, that is hormonal contraceptives. Now when you think of contraceptives, they are the drugs which are used to avoid pregnancy. So they are contraceptives. Now when we talk about hormonal contraceptives, we are talking about the drugs which are used to prevent pregnancy. So how do we use them? There are importantly, we use them by oral route, we use them by injections, injectables, or we use them as implants, that is under the skin. We use them with the help of IUD intrauterine device, as well as we use them in the form of transdermal patches. So these are the different forms, dosage forms where we use hormonal contraceptives. Now, how do they work? What is the mechanism of action? How do they work? So let me draw the uterus. So this is the uterus and the vagina. This is the fallopian tube. These are the ovaries here. Now, what happens when we use contraceptives? You know that FSH, LH are important for the maturation of ova, and LH is responsible for ovulation. That is, on the 14th day, it causes induction of ovulation. So, when we combine the drugs like estrogen plus progesterone, what do? They have negative feedback mechanism, so they decrease LH and they decrease ovulation. So, they decrease ovulation, and that is the specialty of combined oral contraceptive pills which contain both estrogen and progesterone. So number one, they can work in the ovary and they decrease the ovulation. So contraceptives mechanism of action is they decrease ovulation. Second important thing is they decrease the tubal motility. So when the tubal motility is decreased, what happens? The ova cannot move and fertilize it cannot get fertilized with the sperm, or the zygote cannot move down. Even the tubal motility is decreased. Number three, what happens is the endometrium will be not favorable for implantation. So the third mechanism is contraceptives, they interfere with implantation. So they interfere with implantation. And number four, in the cervix, what do they do in the cervix? In the cervix, they make the cervical mucus thick. They make the cervical mucus thick. Now, if the cervical mucus is thick, the sperm cannot easily enter inside. So, when the cervical mucus becomes thick, it inhibits the sperm penetration. So, they inhibit the sperm penetration, and this is the major mechanism of action what we see with progesterone only pills. Progesterone only pills, we call them as mini pills. So that is the mechanism of action. Now remember, almost all the contraceptives have this four mechanism, that is by decreasing the ovulation, by decreasing the tubal motility, interfering with implantation, and making the cervical mucus thick. But the major mechanism of combination of estrogen progesterone is decreasing ovulation. The major mechanism of progesterone only pill is to make the cervical mucus thick. And the emergency contraceptives, the major mechanism is to interfere with implantation of the zygote. Right? So this question was asked, all are mechanisms of contraceptive except. So they are given all the mechanism and one more mechanism by increasing LH. They don't increase LH. If you increase LH, there is ovulation. So we understood the mechanism of action of the contraceptives. Now let us discuss the orally used contraceptives. Oral. In oral, we have something called combined oral contraceptive pills. Then we have one more thing called progesterone only pills. They contain only progesterone. We call them as the mini pills. And then the third one is, it is called as the emergency contraceptive. Emergency contraceptives. So we are discussing the orally used drugs. So let us take up one by one. Let me discuss the combined oral contraceptives. Combined oral contraceptive pills. As the name suggests, it contains both estrogen plus progesterone. The most commonly used estrogen preparation is called ethinyl estradiol, and the most commonly used progesterone preparation is levonorgestrel. It is called levonorgestrel. So, what is the standard dose of ethinyl estradiol? The standard dose is around 50 microgram. It is around 50 microgram, and lower dose is around 35. It is around 35 microgram. Very low dose of ethinyl estradiol is around 20 microgram. So these are combined together. Now in this combination we have something called monophasic pills. Monophasic pills. Now what do you mean by monophasic pills? Monophasic pills means they contain same amount of estrogen progesterone throughout the cycle, right? And the problem with monophasic pills is there is breakthrough bleeding. That's the problem. So if you keep the dosage of estrogen progesterone same throughout the cycle, there is a chance of breakthrough bleeding, meaning in between the menstrual cycle there is bleeding. To avoid that, we came with something called biphasic pill. So what is biphasic pill? The estrogen content remains same throughout the cycle. The progesterone content for 1 to 10 days is different. Again, the progesterone content from 11 to 21 days is different. So by changing this, we are giving different dosage to the patient. Then we have the triphasic pill. Here the estrogen dose remains same, but the progesterone dose changes. That is, progesterone dose from 1 to 6 is different. That is very low. Then from 7 to 11 days, it is moderate dose. Then from the 12th day to 21 days, you use a higher dose of progesterone. So what is the advantage of doing this? The advantage of doing this is the patient will have decreased risk of breakthrough bleeding. So what is breakthrough bleeding? In between the periods, the lady will have bleeding. Usually at the end of the period she will have that. But here in between, if she has, then she has to be shifted to the biphasic or triphasic pill. So here we are mimicking the physiology, because you know that initially 14 days it's estrogen phase, next 14 days progesterone phase. But here what we did in monophasic, we are giving the dosage same, and that's why in between bleeding is common. Then which patient combined OCPs are better? Combined OCPs are better in a newly married couples. That is better. And also it is better after evacuation of molar pregnancy. After evacuation of molar pregnancy, we can prefer combined OCPs. Yes, so that is the point. So we understood the combined oral contraceptive pills. The second important one is the progesterone only pill. Progesterone only pill, and they are also called as mini pills. So they contain only progesterone, and they don't have so much efficacy. What we discussed with combined, they have less efficacy. The efficacy is very less. And what is their major mechanism of action? They can do all the four, but they make the cervical mucus thick. So what happens if the cervical mucus is thick? It is not going to allow the sperm to penetrate. It is taken daily without any break. So that is a specialty of mini pill. Now where do you prefer this mini pill? choice. Which patient it's a choice? It's a choice in lactating women. So lactating women, we don't want to give the estrogen. Seizures, we don't want to give. We don't want to use it in sickle cell disease, the estrogen component. So in that patient, we can use POP. So POP is preferred in lactating women, seizures, and sickle cell disease. So let me write this: sickle cell anemia. Right. So why not? Lactation itself is a natural contraception. Then why are we using it? So it is not a complete contraceptive. So lactational amenorrhea can be seen, but we cannot trust it. So better to give them, that is, progesterone only pill. Now, it is also preferred where estrogen is contraindicated. In estrogen contraindicated condition also we prefer this. So what are the estrogen contraindicated conditions? More than 35-year-old. So more than 35-year-old and require contraception, or if they are smokers, or if they have a risk of DVT, that is venous thromboembolism. So these are the patients where we prefer POP: lactating women, seizure patient, sickle cell anemia, and patients where estrogen cannot be given, like a patient 35-year-old, smokers, and increased risk of venous thromboembolism. So we're done with the second oral drug, progesterone only pill. The third oral drugs, what we need to understand, they are called emergency contraceptives. Emergency contraceptives. So emergency contraceptives are also called as post coital pill, or they are also called as morning pill. So in case of somebody is using the condom and the condom burst open, and they were not planning for pregnancy and they know that they can get pregnant, so immediately that can be started. So most of the emergency contraceptives should be used within 7 to 2 hours. The examples are, we have a drug called levonorgestrel. The name is levonorgestrel, and it is used at the dose of 1.5 milligram. You can give it as single dose. So that is one important aspect, but the usage should be within 7 to 2 hours. Or it is also given within 7 to 2 hours like this, 0.75 milligram, and after 12 hours, again 0.75 milligram can be used. So this is how it can be used. The second emergency contraceptive which can be used is the combined OCPs. Usually this is seen in the primary health centers and in village sites. So what we tell the patient to take 2 tablets of it immediately, and within 12 hours another 2 tablets, and we call it as use-pay method. This method is called use-pay method, and this has to be also taken within 7 to 2 hours. But this has shown to be having less efficacy in preventing the pregnancy efficacy. So the third drug is a progesterone antagonist, that is called mifepristone. Mifepristone has to be used within 7 to 2 hours, and the dosage is 600 milligram. So the dose is 600 milligram. Recently we have come up with another drug called ulipristol. Ulipristol is called as SPRM, selective progesterone receptor modulator. It is given as 30 milligram tablet, and it can be used up to 120 hours. So most of them are used within 7 to 2 hours. This is the one which can be used up to 120 hours, that is less than 5 days. So that is the specialty of this. So this can be a question for you: levonorgestrel, combined OCPs, mifepristone, and ulipristol. Very, very important. So in oral, I told you there are 3 important aspects we need to understand. What are those? The combined OCPs, progesterone only pill, and emergency contraceptive. Yeah. Now when we consider OCPs, oral contraceptive pills, what is the adverse effect? Very, very commonly asked in the exam. Now when a woman is on OCPs, they can develop the mild adverse effect, the moderate adverse effect, and a severe adverse effect. So what are the mild adverse effect? Patient may develop nausea, patient may develop edema, then headache, then breast tenderness, then abnormal bleeding. Abnormal bleeding means the breakthrough bleeding. So there is breakthrough bleeding. Now, if there is breakthrough bleeding, what should we shift the patient to? Shift the patient to biphasic, triphasic pill. So nausea, edema, then headache, breast tenderness, and abnormal bleeding are the other important things. Sometimes patient may miss the period in between also. So these are the problems. Moderate, which the patient will not accept, that is called acne. Then the patient may get the weight gain and the pigmentation of the cheeks, that is called plovasma. So these are cosmetic adverse effects which the patient will not be accepted, and that's why most of them discontinue these things. The severe, you can remember by the C's. What are the severe C's? What is that? C for serious. So what does it happen in CVS? It can alter the lipid profile. They can alter the lipid profile. So what is the problem? It can lead to venous thromboembolism, and that can lead to increased risk of MI and increased risk of stroke in the patient. So the complication is serious problem. And long-term usage can also elevate the BP in these patients. Then another C for CNS. So in CNS, these drugs can cause mood swings. Patient may have mood swings and they may develop depression also. Mood swings and depression. And C, the cholesterol. So cholestasis. So cholestasis leading to gallstones can also happen. So OCPs can increase risk of gallstones. And another C for cancer. So they can increase the risk of cancer. Which cancer? They can increase the risk of the breast cancer. They can increase the risk of the cervical and vaginal cancer. So they can increase the risk of cervical and vaginal cancer. So the cancers are increased by them. Right. So these are the major adverse effect what we see, and sometimes they can increase the risk of benign hepatomas. Benign hepatomas. So these are the problems what we see with OCPs: mild nausea, edema, headache, breast tenderness, abnormal bleeding, that is breakthrough bleeding, and sometimes there is loss of withdrawal bleeding. When it is stopped, they will not get the periods. Moderate is acne, weight gain, and plovasma, and severe is CVS. They can have altered lipid profile, venous thromboembolism, increased BP, mood swings, depression, gallstones, risk of breast cancer, cervical cancer, vaginal cancer, and benign hepatomas can happen. But were there any benefits? Are there any benefits with OCPs? Benefits of OCPs. What are the benefits? Now let me go with the structures and tell you. Ovary. Is there any benefit? Yes, it has shown to decrease the ovarian cyst. Ovarian cyst has been decreased, and also it has decreased the risk of ovarian cancer. Very good. What about breast? We know that it can increase the risk of breast cancer, but it has shown to decrease benign breast disease. Benign breast disease. What about in the endometrium? Endometrium. In endometrium, it has shown to increase the risk of endometrial cancer. It has shown to decrease the risk of endometriosis. Endometriosis. And decrease the risk of fibroids. Risk of fibroid. That is about this. And do they have any effect on the bone? Yes. They have shown to decrease resorption, which is good. that is in the bone. Apart from that, OCPs, they also have shown to decrease the anemia risk, and they have shown to decrease a condition called premenstrual tension. Premenstrual tension. Right? These are the advantages of benefits of OCPs. Ovary, they have an advantage to decrease the cancer. Endometrium also cancer. Breast, not a cancer but benign breast disease. Bone, decrease the resorption, useful in osteoporosis. They can decrease anemia because most of them, they will have menstrual cycle, they will have menstruation, loss of blood, anemia, so that is decreased. And they also decrease the premenstrual tension. So these are the benefits, and these are the adverse effect with OCPs, very commonly asked. Now another important interaction they will ask you in the exam is OCPs with enzyme inducer like rifampicin. So if I combine oral contraceptive with rifampicin or other enzyme inducers, what happens? This will lead to contraceptive failure. A very commonly asked question in the exam. Don't combine OCPs. Another important aspect about OCPs are OCPs, they undergo enterohepatic recycling. So one more pharmacokinetic correlation what we have is they undergo enterohepatic recycling that makes the drug longer acting. But when you combine OCPs with broad spectrum antimicrobial like tetracyclines, what happens? Again, they interfere with the enterohepatic recycling, that will also lead to contraceptive failure. And we have discussed this in pharmacokinetics. Tetracyclines, they interfere with enterohepatic recycling, and OCPs become shorter acting. So these are the things what you have to keep in your mind. So once we know these things, it's important what are the other ways we give contraceptives. Example is the parenteral contraceptives. So parenteral means we give it in other forms, not orally. Parenteral contraceptive. So we use as an injection into the muscle. So that is called IM depot preparation. IM depot preparation, we call it as DMPA. So it is deposited in the muscle and slowly released from the muscle. What is a depot? DMPA stands for depot medroxy progesterone acetate. So that is DMPA. Then we also use a depot preparation that is called norethindrone enanthate. Norethindrone enanthate, it is used as IM depot preparation. Then we use implants. So implants, as the name suggests, they are given below the skin. So patients who have difficulty taking it every day, sometimes they may forget also, for them it is very, very useful. Implants, example is Norplant. So Norplant contains levonorgestrel, and this implant, when you give it, it can work up to 5 years. So they can work up to 5 years. Then we have one more implant called Implanon. So these are the two implants very commonly used. Then we can also use IUD devices. So we put the IUD devices, and from that we release the drugs. The name is called Progestasert. So these IUD devices, they release the drug slowly, and they will also work for long periods. Then we have another parenteral contraceptive, that is transdermal patch, and these patch are applied as once weekly patches, once weekly for 3 weeks, and we give 1 week gap. So patient has to apply this once weekly patch, and 1 week gap has to be given, because we know that 28-day cycle. So 3 weeks we give it, and 1 week we give the gap. So these are the different ways of giving contraceptive. Okay. So basically remember, contraceptives, hormonal contraceptives, we can give them oral, we can give them as injection, we can give them as the IUD devices, or we can give them as patches, or we can give them as depot preparation. In oral drugs, we have combined progesterone only pill and emergency contraceptions. What is the major mechanism of action? Number one, they can inhibit ovulation, they decrease tubal motility, or they make the endometrium may not be compatible with the zygote. So zygote implantation can be interfered, or they can make the cervical mucus thick, so the sperm will not get penetrated. So combined OCPs are best for newly married couples, right? And monophasic pills, the problem is breakthrough bleeding. That means in between the menstruation, they will get, in the cycle, they will get the bleeding, not during the menstruation. So that is called breakthrough bleeding. To avoid that breakthrough bleeding, we use biphasic, triphasic pills. I told you what is the adverse effect of the OCPs, the mild one, nausea, then edema, nostalgia. Then they will have the abnormal bleeding, that is breakthrough bleeding. So then shift the patient to the biphasic or triphasic pill. The moderate one is acne, weight gain, and cloasma. The serious ones are the CVS, MI, and stroke. BP is increased, the gallstones, and the mood swings and depression, and the risk of cancers like breast cancer, the cervical and vaginal cancer. Benefit: they decrease the benign breast disease, they decrease ovarian cancer, endometrial cancer, endometriosis, fibroid. They decrease the bone resorption, they decrease anemia and premenstrual tension. So that is about OCPs. One interaction they will ask you in the exam is OCP with rifampicin, contraceptive failure. OCPs undergo intrahepatic recycling. When you combine tetracycline, the intrahepatic recycling is interfered. The OCPs are shorter acting, so that will also lead to contraceptive failure. So that is about hormonal contraceptives. Thank you all.